You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 11th, 2023. Our topic is Asthma COPD overlap. Our presenter is Dr. Gary Salzman. He is a professor of internal medicine in the section of respiratory and critical care medicine at the University of Missouri, Kansas City School of Medicine.
Our second presentation today on Conferences Online and Allergy on September 11th, 2023. We have Dr. Gary Salzman, who will be presenting on asthma COPD overlap. Dr. Salzman is professor of internal medicine and a pulmonologist at University Health here in Kansas City. He's provided allergy training for many years. I spent time with Dr. Salzman when I was in training, so appreciate that you're doing all the good work that you do. So with that, we'll hand it over to you. Just as a fair warning, if we get down to the end of the hour, I'll send a little 5-minute warning across. And at 2 minutes, if we're still going, I'll just kind of show up on the video so you know we're getting close to the end. So, okay. All right. Thank you for being here, Dr. Salzman.
All right. You're welcome. All right. Can everybody hear me okay?
We can.
Okay. And you can see the slides? Okay. So we're going to talk about asthma COPD overlap. I got no disclosures. This has been COPD and asthma. The correlation has been going on since about 1960s. So the Dutch hypothesis was talked about, where there was overlap between bronchitis and asthma from childhood to adulthood to elderly patients. So this has been talked about since the 60s. And then more recently, with molecular biology research, we've identified some shared overlapping pathways involving several genes that overlap between COPD and asthma. So there are some polymorphisms in people with asthma and COPD that support that these two diseases share some biological characteristics. The implicated genes include the following at the bottom. So what are some of the pathways for asthma COPD? So a common one is childhood allergic asthma resulting in reduced lung function. And this, the asthma actually may resolve, particularly in little boys, but then they start smoking and then have worsening lung function starting at a lower level to start with, and then develop COPD. The other is a lifelong smoker with COPD, and then late onset features of eosinophilic inflammation and airway reversibility. So COPD first and then asthma later. And there's some evidence of Th1 inflammation, COPD, and Th2 and asthma inflammation. So it's certainly asthma COPD overlap is certainly heterogeneous. So you can have an eosinophilic COPD patient versus a smoking asthmatic. So it can start with COPD or it can start with asthma. Some patients may have more characteristics of COPD or more characteristics of asthma. So oftentimes there's more of a preponderance of one of these diseases over the other. And we direct the therapy at the predominant phenotype. Whether it's COPD, we direct it more towards COPD. If it's more towards asthma, we direct it more towards asthma. But it must include anti-inflammatory therapy. Bronchodilators alone are usually not effective in asthma COPD overlap. So you have to include some anti-inflammatory therapy. So one of the important things in asthma to remember is in asthmatics, if we have untreated inflammation for years and years, that's, for example, a patient that just takes beta agonists, does not take any anti-inflammatory, no inhaled corticosteroids. Over time, that patient that started with asthma and untreated inflammation will develop airway remodeling. The airway will remodel, will get smaller, and then you'll develop a fixed airflow obstruction. And I take care of patients who have had asthma for decades, who never smoked, but now have irreversible airflow obstruction because of airway remodeling, because of untreated inflammation and asthma, and now have a clinical picture that's more consistent with COPD than asthma. They have fixed airflow obstruction, they have poor response to bronchodilators, poor response to corticosteroids, because they have fixed airflow obstruction from this airway remodeling. And this is one of the major reasons why we focus so much on treating inflammation and asthma, and we don't allow patients to go without treatment of inflammation. We do not rely solely on bronchodilators. We rely on anti-inflammatories as well as bronchodilators to prevent this airway remodeling and fixed airflow obstruction, and later in life, more of a COPD picture. So the spectrum of COPD really has lots of overlap. So we've got airflow obstruction here, we've got emphysema, we've got chronic bronchitis, we have asthma, and we have COPD here. And you can see by the Venn diagram that there's a lot of overlap. About 80% of patients with COPD have associated chronic bronchitis, but some of the patients with asthma also overlap with COPD. So American Thoracic Society made this statement that sometimes it's virtually impossible to differentiate patients with asthma whose airflow obstruction does not remit completely from persons with chronic bronchitis and emphysema with partially reversible airflow obstruction and bronchial hyperresponsiveness. Now, people believe, some people believe, oh, well, all COPD patients have fixed airflow obstruction, they never have reversibility, and all asthma patients have reversibility, and they all have bronchodilator reversibility. Well, that's actually not true. A significant number of patients with COPD have airway hyperresponsiveness. They meet the criteria for bronchodilator response, and a significant number of asthma patients, particularly when they're stable and well controlled on medicines, or if they're not flaring up and they're not exposed to allergens, they may not have hyperresponsiveness. So there's quite a bit of overlap, and it's not as simple as you would like it to be. So going through the differential diagnosis, that the classical findings in asthma is early in life onset of asthma, often in childhood, where COPD is later in life, usually midlife. Usual etiology in asthma, we know it's immunological stimuli, family history of asthma, irritants. Whereas COPD, cigarette smoking exposure and other risk factors are the inciting event for COPD. So in terms of the course, asthma is more intermittent, COPD is more chronic and progressive. Airflow limitations are largely reversible with asthma, partially reversible in COPD, but there is some overlap here. Clinical features of asthma, obviously episodic wheezes, chest tightness, dyspnea, cough. Where COPD, it's chronic cough, sputum production, and persistent or worsening shortness of breath. And then, of course, inflammatory mediator in asthma is basically eosinophils, and for the most part, COPD is neutrophils. So what defines asthma COPD overlap? There's been several proposals, but this is one diagnostic criteria. So the presence of chronic airflow limitation in a smoker or ex-smoker patient, 35 years or older, FEV1 FVC ratio less than 70%, at least a 10-pack year history of smoking, current diagnosis of asthma, post-bronchial dilator greater than 12%, 400 cc's, or the existence of a very positive bronchodilator response, and or eosinophilia greater than 300. So there's been several different diagnostic criteria. Certainly smoking is the big issue in COPD, and we don't really see COPD in non-smokers. There's some other toxins. We see people that have lived in third world countries where they cook over wood burning stoves or heat their houses with fire. That exposure can cause COPD. It's usually in women because they're responsible for the cooking and heating of the houses. But smoking is a predominant one. And so this is a kind of a classical slide by Fletcher that talks about in people that never smoked are not susceptible to cigarette smoke. This is what happens to your FEV1 over time. So there is a decrease as the individual ages from age 25 to 75. If they smoke regularly, you see the yellow line, they're going to have a continued downhill course of their lung function, disability, and death. If they quit smoking, then that's going to straighten out their curve in terms of their loss in lung function. And even if they get down to very severe obstruction at the end of their life, they stop smoking, they can still prolong their life. So quitting smoking is still important at any age. So definition of COPD. So disease state characterized by airflow limitation that is not fully reversible. The airflow limitation is progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases. And then COPD should be considered in any patient that has these following symptoms. And for the most part, these are some of the most common symptoms of COPD in smokers, and this is what we see with pretty much classical COPD. Spirometry obviously is essential. We want to get spirometry to detect what their FEV1 FVC ratio is. They have reversibility, so the spirometry is very important. And then oftentimes in COPD, we do get imaging, and this, of course, is imaging that shows hyperinflation. So this would be consistent with emphysema, a flattened diaphragm, hyperinflated lungs. This is kind of the classic hyperinflation from COPD. Diagnosis of COPD, we have obviously risk factors, age, symptoms, lung function. We do know that quite a few patients with COPD are undiagnosed. About half of the patients with COPD don't have a formal diagnosis of COPD. Prognosis obviously depends on several things. Good prognosis, people that are younger, people that quit smoking, that have higher FEV1s, and the patients that have reversibility of their airway obstructions, they do better. So actually asthma COPD phenotype has a better prognosis than the other poor prognosis: older age, hypercapnia, hypoxia, tachypnea, dyspnea, fixed airflow obstruction. Those would all be poor prognostic signs. So you've probably seen this, the pink puffer and the blue bloater. Pink puffer, more emphysematous patient. They maintain their oxygen saturation, but they have pretty severe dyspnea because of the hyperinflation. Whereas chronic bronchitis, they have more sputum production, and they're more hypoxic. As you can see, he's cyanotic, and so these patients develop more hypoxemia. They have more sputum production. So pink puffer, blue bloater. But COPD involves several different things. There is inflammation involved, which is a response to a toxic exposure to mainly cigarette smoke, structural change, bronchoconstriction, all leading to airflow limitation. Bronchoconstriction, COPD, may be partially reversible, and it may develop after exposure to tobacco smoke or environmental insults. And chronic inflammation with increased amount of smooth muscle in the airways. Airflow obstruction can be either irreversible or reversible. Irreversible related to fibrosis, loss of elastic recall, destruction of alveoli, and reversible related to inflammatory cells and mucus and exudate and smooth muscle contraction in the airways. But sometimes it's difficult to differentiate COPD from asthma. So structural changes and COPD, get epithelial changes, fibrosis in small airways, destruction of alveolar walls, vascular changes often leading to pulmonary hypertension and more severe COPD. So COPD is a disease of multiple components: inflammation, bronchoconstriction, and structural changes. So how do we diagnose it? Obviously, we look at spirometry, a ratio less than 70%, history of tobacco smoke or occupational dust or chemicals, indoor or outdoor air pollution, recurrent respiratory infections, and the history of chronic bronchitis. And chronic bronchitis is based on symptoms alone. You don't need anything else. If you have cough and sputum on most days for at least 3 months of the year for at least 2 consecutive years, with other diseases ruled out like TB, then that's chronic bronchitis. And they also commonly can also be concurrently diagnosed with emphysema. So obviously we want to try to help people quit smoking. We actually did a study over at University Health. They did it with students. We're in the primary care clinic. They asked every patient who successfully quit smoking, had quit smoking for at least a year, how they quit. You just asked them what they did to quit smoking, and the results were fairly interesting. 90% of the patients said they quit cold turkey. Only 10% used any pharmacological therapy, which I think is really fascinating because pharmaceutical industry would suggest that every patient that smokes needs to have a prescription for a pharmacological agent, nicotine replacement, Wellbutrin, Chantix. But it's interesting in a real life setting of people that actually quit smoking, 90% of it did it a cold turkey. So to me, that would mean that the first step should be try cold turkey and see if that works. If that doesn't work, you can always go to pharmacological therapy. But I think with that kind of data, I would suspect that at least having people try to quit cold turkey without pharmacological therapy would be a good first step. And obviously, it's no expense and no side effects from going quit turkey without pharmacological therapy. So one of the goals of COPD therapy is to prevent exacerbations. So when someone has an exacerbation, there's several different things that happen: a negative impact on quality of life. They have an accelerated lung function decline over and above what they would get from smoking, increased mortality, economic cost, and obviously impact on symptoms and lung function. So when someone has an exacerbation of COPD, we do prescribe antibiotics for increased shortness of breath, increased sputum volume, and increased sputum purulence, and for those patients who require mechanical ventilation. So we do treat COPD exacerbations with antibiotics. We also use non-invasive ventilation in patients with more severe COPD exacerbations, BiPAP or AVAPs. We do use prednisone therapy. Usually we're talking about 40 milligrams a day for up to 5 days, and not to use it for more than 2 weeks. So shifting now to asthma, we talk about people that present to their primary care physician. We're talking about over half of the patients are going to have uncontrolled asthma when they're coming to their primary care physician's office. And a lot of times that's not identified. And then even patients who will come to the office for a non-respiratory problem, nearly half of those patients had uncontrolled asthma. So one of the things that, and certainly in primary care, that we see is just an overuse of beta agonists. We know that beta agonists alone should not be used for even intermittent asthma, but we see about 1 to 3 adults with asthma are using their albuterol at least once a day, which would indicate that their asthma is uncontrolled. And certainly if they're having daily symptoms, they're already at moderate persistent asthma. So that's an issue. And some of the risk factors for death from asthma, obviously current use of oral corticosteroids, difficulty perceiving airflow obstruction, comorbidities with other diseases or heart disease, serious psychiatric disease, low socioeconomic status, and illicit drug use. So it's interesting. In COPD, if they have overlap, it probably improves their prognosis. If you have asthma and you also have COPD, it probably worsens your prognosis. So this is a cut surface of the lung that shows a patient who died from asthma. You can see mucus plugs in the airway, all this inflammation in the airway, which just highlights how important it is for anti-inflammatory therapy for asthma. And obviously, when someone starts to develop asthma exacerbations, to using systemic corticosteroids to treat this inflammation to avoid this fatal asthmatic lung. But this is pretty impressive. And then if you look at the airway, so this is a normal airway. You can see a nice normal airway, alveolar structures here. And this is a patient who died from asthma. Basically, the airway is almost completely obstructed. You have a thickened basement membrane. You have all these inflammatory cells in the submucosa. And basically, the patient suffocated to death from uncontrolled inflammation. So inflammation is key in asthma, and we need to aggressively treat it. So here's a case, 35-year-old lady, never smoked, history of asthma since childhood, comes in for routine appointments, says, all I need is refill on the albuterol inhaler. She uses it 1 to 2 times a day for wheezing. She wakes up 2 to 3 times per week with coughing, completely relieved with albuterol. She's unable to walk up 1 flight of steps due to dyspnea. Her vital signs are normal. So really, she's at moderate persistent asthma. She's having daily symptoms. She's waking up more than 5 times a month. Reduced spirometry, we're going to see marked abnormality. So this patient really has more moderate persistent asthma and shouldn't be treated with as needed beta agonist. And in my opinion, should not even be treated with smart therapy. Should have regular treatment of an anti-inflammatory. So how do we tell in terms of control? The asthma control test is one validated test that you can use in the office to have them look at over the last month what type of symptoms they're having and then add up the score. 19 or less means the asthma is not under good control. And so this is kind of a validated control test to kind of look at several different factors, 5 factors over the last month to kind of determine asthma control or not. Bronchoconstriction is obviously a big part of asthma. Here's the airway before, allergen challenge. Here's after. You can see that marked bronchoconstriction occurs in asthma. And then also, more importantly, we have airway mucosal edema. This is an airway that's inflamed and edematous from inflammation. Now, bronchodilators are not going to relieve this obstruction. The only way at this point that you're going to relieve this obstruction is by systemic corticosteroids. Inhaled corticosteroids aren't going to do it. They can prevent this, but they're not going to treat it. So you would need systemic corticosteroids. So what's the effect of inhaled corticosteroids in asthma? So here's a bronchial biopsy of a patient with uncontrolled asthma. You can see that there's no cilia here. The epithelial layer is disrupted. The basement membrane is disrupted. You have lots of inflammatory cells in the submucosa. After 3 months of treatment with an inhaled corticosteroid, in this case budesonide, we have restoration of the cilia. The epithelial layer is intact. The bone marrow, the basement membrane has come back, and then we have marked decrease in inflammatory cells. So this is the same patient and a biopsy of their bronchial tissue. So inhaled corticosteroids certainly have a significant effect at changing anatomically what the airways look like and their function. So, of course, you all know that every patient with asthma should have an asthma action plan. They should be able to self-manage their patients, and so that when they're starting to increase in symptoms, they can adjust their therapy. And if they're getting in the red zone, they should be able to have access to prednisone so they can take it. And then they need to know when to go to the emergency department for hospital type treatment. So all of our patients have asthma action plans and can self-manage their symptoms to try to prevent ER visits, prevent hospitalizations. So as many of you have worked with me in asthma clinic have identified, one of the most important and common causes of a patient not responding to asthma treatment is that they don't have asthma, they have something else. Just saw a patient this morning in the ICU who's been intubated 9 times for asthma, and on further review and looking at her vocal cords and examining her, she doesn't have asthma. She has vocal cord dysfunction, which is why she's not responding to asthma medication. But other things, heart failure, reflux, pulmonary embolism, sarcoid, pulmonary fibrosis. So it is important to start back at the beginning when you have a patient with uncontrolled asthma and trying to establish, do they indeed have asthma? And if they have asthma, do they have another comorbid condition in addition that needs to be treated? Do they have airway remodeling? If they've not taken appropriate treatment for their asthma? Do they have persistent exposure to triggers? They have a cat that they're allergic to that they're sleeping with, but they're not taking a controller medication, or they're having refractory asthma. All those would be causes of uncontrolled asthma. So we know that inhaled corticosteroids can prevent death from asthma. This is a study from Canada that indicates if a patient didn't refill any of their inhaled corticosteroid doses, this was their rate of asthma death over 2 times the control, whereas if they were taking it every month, they remarkably reduced their risk of asthma death. And if they took it half the time, it was somewhere in between. So inhaled corticosteroids do prevent death from asthma. Antibiotics are not generally recommended for treatment of acute asthma exacerbations, except for comorbid conditions, fever and purulent sputum, evidence of pneumonia, suspected bacterial sinusitis. Obviously, if you have asthma COPD overlap, those patients may need antibiotics if you're treating a COPD exacerbation in a smoker or patient with overlap. So we may use antibiotics more in this overlap type patient. Again, we want to use some validated questionnaires. We talked about the asthma control test, which is a good test to look at whether a patient is controlled or not controlled. And then obviously spirometry is very essential. We want to make sure that we test spirometry to make sure we have a correct diagnosis, to make sure that we're responding to therapy, that lung function is improving with our therapy, that bronchial hyperresponsiveness is eliminated with adequate therapy. So what about treatment of asthma COPD overlap syndrome? So certainly eosinophilic COPD, we're talking about either greater than 150 or 300 total eosinophil counts. We're going to add an inhaled corticosteroid to bronchodilator therapy to reduce exacerbations. These patients may be good candidates for triple therapy, ICS/LABA/LAMA, and that has been shown to reduce exacerbations, improve lung function, and improve quality of life in the IMPACT study. There's been at least 2 biologic agents that also been shown to improve symptoms in eosinophilic COPD. So COPD with elevated serum eosinophil counts. Smoking asthmatics have been looked at. Adding on antimuscarinic therapy here in this study, adding tiotropium on reduced exacerbations by 21%, improved lung function and symptoms. So antimuscarinic therapy is important in these patients. Azithromycin's been used to reduce exacerbations regardless of the eosinophil count in smoking asthmatics. So that is another. And then patients with elevated IgE, looking at omalizumab, reducing exacerbations with elevated IgE levels. So you want to avoid long-acting beta agonist monotherapy, particularly in patients that have asthma COPD overlap. The asthma part of it, we know for sure that long-acting beta agonist alone has been shown to increase mortality in asthma and should be avoided. Now the whole issue of intermittent symptoms and asthma COPD overlap. And this goes to also intermittent symptoms in asthma alone. So certainly I'm aware that the GINA guidelines now recommend PRN use of Symbicort in patients with actually intermittent and mild persistent asthma. And I guess I have some disagreements with that. One of those is the package insert for Symbicort specifically says not to be used for acute relief of symptoms. And that certainly raises some medical legal issues in terms of a patient had a bad outcome and you are prescribing a PRN Symbicort basically against the manufacturer's recommendations. The other issue is the GINA guidelines recommend up to 12 puffs a day of Symbicort. If a patient's taking 12 puffs a day of Symbicort, then it's likely that they're going to run out of their inhaler before the end of the month. Their insurance is not going to give them an additional inhaler if they've run out of their Symbicort, so that could be an issue. The other is, I think that what makes more sense to me on intermittent symptoms in a patient you don't want to have on therapy year-round is instead of using a PRN ICS/LABA, to put it in the asthma action plan in the yellow zone. And when the patient starts to have increasing symptoms that are generally related to most commonly viral URIs, to go ahead and use the ICS/LABA. It can be any of the ICS/LABAs, doesn't have to be Symbicort, whether it's daily or BID, whichever is recommended for that individual ICS/LABA, for 2 straight weeks, just like you would a pulse course of oral prednisone. Instead, you would do a pulse course of ICS/LABA with PRN albuterol ipratropium in the action plan, and do that instead of an as-needed Symbicort. I think that makes more sense. It also separates the reliever from the controller medications. It's clearly listed on their action plan. And it makes sense that most of these increasing symptoms on intermittent patients are related to viral URIs, which last about 2 weeks. So it makes sense to use the ICS/LABA on a regular basis for 2 straight weeks and then stop, and then they don't need it for the rest of the year instead of using as needed Symbicort. So that's my personal opinion. It's not part of the GINA guidelines, but I think it makes more sense to do it that way. But yeah, in asthma and in COPD, we can see these intermittent patients who don't need therapy year-round, but when they start having increasing symptoms, they need something. And my approach is to do a 2-week course of an ICS/LABA at the recommended dose, whether it's once a day or whether it's twice a day, to make sure that we do an adequate amount of time to resolve that within their usual URI. And they can use as needed albuterol with that. And that, I think, works better than the PRN use of Symbicort. So obese patients, I think, are a separate phenotype in both asthma and asthma COPD overlap, and that these patients tend to have resistance to beta agonists. Just like they have insulin resistance, oftentimes they have resistance to beta agonists. And so short and long-acting antimuscarinic anticholinergic agents can be very effective at relieving symptoms in these more obese patients. Obese patients tend to have more severe symptoms, worse lung function, more exacerbations, more hospitalizations. But it is clear that these patients respond much better to antimuscarinic agents as opposed to beta agonists. So I make sure that that's a part of their therapy in obese patients. And oftentimes, even for a reliever, instead of albuterol, I might use a combination of albuterol and ipratropium, a Combivent. It seems to be more effective in these obese patients that have more issues in terms of exacerbation. So that's something to keep in mind in these patients to make sure that you're using antimuscarinic agents. So the goals of therapy really are different between asthma and COPD. So my goal in asthma is to have normal lung function, rare symptoms, no activity limitations. If they want to run a marathon or do a triathlon, or go outside and play with their kids when it's hot outside, that they should have no activity limitations with appropriate therapy and basically no exacerbations. So the level of goals in asthma is rather high, and most of the time you can meet those goals, which is important for trying to separate it from COPD, where COPD and older smokers, I'm not going to be able to get to these goals. So my goals in COPD are to reduce exacerbations, improve symptoms. I'm not going to be able to hit a home run in COPD like I am generally in asthma. And maybe get a base hit or a double. I'm not going to hit a home run. So asthma COPD overlap is somewhere in between. And again, it's whether it's more predominant asthma or more predominant COPD. It just depends on which one is more predominant. And most of these overlap patients are predominantly one asthma or more COPD, or one more than the other. And so then the goal would be focused somewhere in between. But for pure asthmatics, have very, very high expectations for goals. COPD, relatively low expectations. The main one is reduce exacerbations and improve symptoms. We can improve lung function with asthma. COPD, generally, we're not going to be able to significantly improve lung function. And asthma COPD, you're going to be somewhere in between. So these are my references right here. And I will certainly open it up to questions.